What a dirty trick, rushing you when you're getting your gloss on. Now, my favourite boss I've ever had was a director of nursing called Shirley Richardson. And whenever I was a little bit agitated about getting up for a presentation or whatever, she always used to say, get your lipstick on and get up there. So I'd never like to get up now without my lipstick, thanks to Shirley. So thank you for that lovely introduction, Ken. So I have been working on the care home initiative in Gateshead, but it's actually been a long journey. And there's a few reasons for that. But one of the reasons is that because these people that live in our care homes in Newcastle and Gateshead, definitely, they have very, very complex needs. And I've come to learn that that means you need a complex response and you need a wide system with lots of different services in it. So we started our journey in 2008, and I would bore you all rigid if I tried to recap and go right back to 2008. So what I've got instead is a little film that just lasts about 3 minutes that hopefully will work, and it'll summarise it. And then I'm going to go on and share with you some of what we've done in the last 2 years when we've actually been a care home vanguard. For the last 2 years, the Newcastle Gateshead Care Home Vanguard has been making waves in the care community. This is for their innovative approach to improving the health and well-being of older people living in care homes. Gathering acclaim and awards along the way, the transformation from local initiative to national vanguard didn't happen overnight. Back in the days of practice-based commissioning, the care community in Gateshead saw there was an opportunity and a need to improve the effectiveness of care to reduce avoidable hospital admissions. An audit of 5 care homes revealed previously unseen levels of frailty and prompted a major rethink of how agencies could work together to cooperate and better deliver care for residents with the most complex needs. Alarmed by the audit's findings, the Gateshead Care Home Initiative started to take shape. Firstly, by flipping care from a reactive to a proactive model. The right individuals were identified who could help to guide the journey on the challenging new course. We brought a nurse specialist on board and began to address the concerns highlighted in the Darcy report, with a newly appointed GP test and refine our linked practice model. These changes resulted in the initiative receiving significant support, marking the end of the pilot scheme and the beginning of our substantive service. With the introduction of new technology, improvements to information sharing and GP incentives. 2013 saw the initiative receive better care funding and the formation of the Newcastle Gateshead Clinical Commissioning Group. This allowed Newcastle care homes to benefit from lessons learned in Gateshead. From here, the work continued apace with the introduction of MDTs, virtual wards, a second community geriatrician, and the reprocurement of community health services, forging onwards into 2015 when we were awarded Vanguard status. Using this momentum, the newly formed Vanguard adopted a regional approach and began to explore issues beyond severe frailty and end-of-life care. 2 years on, we've created a robust case for change by gathering good business intelligence, matching it with clinical evidence, and with the journey nearing its end, we thought we'd share some good guiding principles that have helped keep us on the right track. Find your clinical engagement superstars. Having the right people on board is key. Collect the right data, analyse it carefully and share it. Work closely with the whole sector, especially primary care teams and care home staff. Collect local intelligence and use it alongside data to inform service developments. And finally, accept change. Things will come along that you can't see coming, but just keep going. Much of what we've learned from our work to date has been developed into off-the-shelf products, freely available to download from our website, which we hope will prove helpful when sailing the 6 seas. Good luck and bon voyage. that's given you a flavour of what a very long journey we've been on. We have made a difference to the lives of older people living in care homes in Newcastle and Gateshead, and the lives of the people working in care homes as well. But we didn't understand that we had to do that in the very beginning, to be honest with you. Now I'm going to get the numbers bit out of the way first of all. So obviously we've been measured by NHS England, by their new care models team over the past couple of years, and what we set out to do, what we had to do, was to reduce older people going into hospital when they didn't need to. But we absolutely have to understand sometimes hospital is the only place to be, but your window of opportunity for getting in when people have very complex needs is so tiny that you do need a complex response from the whole system. And Sharon alluded to that in her opening speech this morning when she said, actually, if you're a community nurse, just because someone lives in a care home rather than their own home doesn't mean they shouldn't have access to you, and we'll have to all learn to work together and get much better at that. So across Newcastle and Gateshead, you can see that we did manage to achieve that. That we did reduce the length of time people spent in hospital, our care home residents, and also the numbers that were being admitted there in the first place. We're one of 6 care home vanguards, as Sharon explained this morning. If you add the other 5 together, they didn't achieve what we achieved on our own. And I don't say that with any great level of conceit. I say that because I want to point out to you what we had that the other 5 didn't have. And what we had was a massive clinical engagement forum. So none of what we have achieved might have brought cost savings to the system through less people going in hospital, improved the work and lives of people in secondary care as they had to flow patients, they had less to flow through their very pressured hospital system. But that didn't cost any money. The only thing that cost money were the actual vanguard team. And on the 31st of March, they will all disappear. All of the changes happened through people that were already there, particularly care home staff, I would have to say. And people were in hospital less as well. But the other things that we were measured on were what they were going into hospital for. So we had a mandate to reduce older people going into hospital with a urine infection. Now, when I first took up this post, I thought, well, I wonder why we're only looking at urine infections. Why aren't we looking at every reason they go into hospital, non-elective? But it soon became clear. I am a nurse specialist for older people. I've spent all of my career specialising in the care of older people. So I did understand that, illness in this group of people doesn't present as illness, it presents as functional change. And that means that you have to consider lots of different things. But I couldn't tell you how we are at our all-time low. I couldn't give you one reason why we are at our all-time low for older people going into hospital from care homes with a urine infection. It might be that the community nursing staff now support the care home staff with the administration of subcutaneous fluids, because we learned that the care home staff did something so infrequently. Providing the education, the sitting in the classroom bit, was easy, but what was much more challenging was them to become competent at doing all these new elements of care. And added to that, even when they became competent, holding that competency. So education and training is only one tiny little bit of it. So we introduced a dietitian to do some education and training in the classroom, but we thought if we learned, the educational people that we had in our clinical engagement forum, they told us only 10% of your learning happens in a classroom. So we thought, well, dietitian, get in and work with the care home teams then. So she then did the classroom bit in their day room or learning room, resource room, whatever they had in the care homes. Then she would follow that up with some work-based learning where she would work alongside them, and they would, talk about best practice for thickening fluids, for example. She would work with the chefs for increasing calories and having a food-first approach rather than an oral nutritional supplement prescribing approach. So we measured that as well, and you can see from that slide that that's gone down. So already then, we've got a dietitian working in there with a new way of education and training, work-based learning, as well as classroom. We've got the community nurses doing the subcut fluid administration. We found that we sometimes had to wait 24 hours for community pharmacies to get the bag of fluids when we wanted to put that up. So we let the community nurses, we provided a patient group directive, a PGD, and they then held the fluids in their store of medicines that they had in their community base. So that meant we could have much quicker access to it on occasions. So a whole range of things will have led to that reduction in urine infection. We'll also have the community nurses doing intravenous antibiotic administration in the community. Not that we wanted to exclude the community nurses from it, but it became one of those things that was so infrequent it was hard to hold the competency in. So it's another example of how we had to work together. So we had that. So just for my own interest, though, I think I'll look at chest infections as well, because we had clinical audits done that said a lot of older people are going in with chest infections. And we found in this 2 years that we have had a reduction in that. One thing that we have learned, and I would say this, to have a look at your own data for wherever you work, because it is very different. When I benchmarked us in Newcastle and Gateshead with all of the other care home vanguard programmes, we found that our patient profile, our care home resident profile, was very different. For us, 65% of our residents have a formal diagnosis of dementia. And when we did a little clinical audit wondering, I wonder how many might have it but aren't yet diagnosed, we think that that's about 72%. So in Newcastle and Gateshead, our residents only live in care homes for just under 2 years. So you know that by the time you go to live in a care home in Newcastle and Gateshead, that you're probably moving into the palliative phase of your life. We also know from the clinical evidence base that it's really, really hard to recognise when you're flipping from palliative into end of life with frailty and with dementia. It isn't like other diseases, like some of the cancers, where we understand the trajectory so much more, and you can work with families and work with influence your care planning through understanding that trajectory. We're all just learning about dementia, and we're all just learning about frailty. Now, in that film, 2012, when we made our substantive service, when we put it in after we started our pilot in 2008, I can remember when we got to the end of 2012 and writing the final report, we were making recommendations for a frailty service. And a commissioner in another land, so not Gateshead, which is where that pilot happened, a commissioner in another land said, Lesley, we couldn't have anything with frailty in the title. And frailty, that F word, wasn't being used very much back then. But everybody's using it now, aren't they? And do you know what I think the biggest challenge of frailty is? That the whole world's talking about it, but even those most experienced in elderly care are only just getting their heads around it. And that's why it's hard to really bottom out and say, right, you're flipping from palliative into end of life. And we wouldn't have started to think about end of life and palliative care if we hadn't sought to understand who are our people living in care homes. And benchmarking with one of the other vanguard sites down in the southeast, their people, 78% of them self-funded. Under 30% of our people in Newcastle and Gateshead self-fund, which tells you that you have to absolutely need to live there before you move into a care home. So your needs are going to be much more complex. Our people, as I've said, live there for under 2 years. In my peer vanguard down the southeast, they live there between 7 and 10 years. The average was 8.2 or something like that. So it's a very different group. And when you think about the Enhanced Health for Care Homes framework that is an exemplar of practice, in order to get the most out of that and influence what we commission and what we provide, then we really need to match that with the needs of our people. So I would just say it's really worthwhile bottoming out your data, identifying your patient profiles, because then it helps you to target where you need to target to achieve whatever it is you want to achieve. Now, these are the things that we signed up to These are the things that we were measured against, as I've said. So we focused our work on this. But understanding much more about our residents really helped us to do that. I think that, we're all very familiar. We all talk about, look, we're all about safety, we're all about quality, and we're all about experience. But I don't think I spoke about the experience of the workforce 2 years ago as much as I do now, because experience is those two things. And Sharon alluded to that. We're facing immense challenges in terms of nursing, particularly, but right across the whole workforce. Then if you think about those of you who are nurses in the room, and I know that some of you are, those of you who are the vital support workers, healthcare assistants, whatever your title is, who work with nurses, as Sharon said, you carry out nursing duties. But if you think about nursing, and this is a world where the multidisciplinary team is king, but it's nursing that has the numbers. If you think about nursing older people still carries little kudos within the profession. And people still think it's somewhere you go to work if you're a little bit short of the mark. I'm going to just leave that thought with you. So to come back to Vanguard then, we set ourselves up in 6 work streams because we reckon that as well as influencing all of those metrics, we'd signed up to the metrics, but we didn't know at the time that they were all clinically focused. We said we might want to do some other things. We might want to influence the flow of CHC, so that for the care home teams, they didn't wait so long, so that our processes were slicker. That would have fitted into number 1. We knew that we wanted to do some engagement, and I want to tell you about some things I wish we hadn't done, or some things that I wish we had done differently as well. And in engagement, in that little work stream, we went out to a lot of older people who didn't live in care homes, and we didn't speak to people who worked with care homes or particularly sought out older people who'd had relatives in care homes, and we asked them what they would like if they went to live in a care home. And what I learned from that was, at the end, do you know what? That was the same as saying, what would you like if you went to live on the moon? Because if you have never lived in a care home, or you've had a relative in a care home, or you've worked in a care home, you didn't really know what you were answering. So I concluded we could have done something, we could have made much better use of our time with that engagement forum. So I think that's a massive thing. When you want the views of people about the services that you're going to commission or provide, just stop and have a little think, who will be the right people to inform? Because that was a mistake of ours. I think the workforce, we've learned such a lot from our care home colleagues. But I want to say this to you. Sharon, you alluded this morning to some of those headlines that spoil the image of nursing. But maybe they are the things that the media likes because it makes us buy the papers and all the rest of it, and they don't put the good stuff up there. I have learned that some of the best care of older people happens in our care homes in Newcastle and Gateshead. I've spent lots of time with patients and their families. And while we have to learn from what goes wrong sometimes, or what we didn't get quite right, and I've shared, and I'm going to share more things that we didn't get quite right, but I can tell you this, my best patient story about hydration comes from care home staff, and the best hydration care I saw in care homes. My saddest patient story comes from secondary care. Now, if you think about workforce, care home staff haven't had access to education and training in the same way that all those NHS people have. And it's a massive learning thing when you start to think, well, here I am, I've spent all these years in the NHS, I've been privileged to work with nurses who are still today considered to be among the best in the business. I've been privileged to be part of big MDTs where I've worked with geriatricians who are my favourite doctors in the whole world. And I have one, if any of you know QE Hospital in Gateshead, it's on the top of a hill called Sheriff Hill, my King David of Sheriff Hill. I would quote him forever because this is, it is a world where the multidisciplinary team makes the best things happen. And when we work together, we'll learn from one another. And if we weren't working with care home staff in the best way possible, we weren't learning from them. But yet we were sitting where we were sitting thinking, if I can just get out and tell them to do X and Y and Z. We actually started to design a transfer of care form, and only at one point did I look up and think, well, hang on, how are we going to do this? We haven't got anybody from a care home around the table, but we were so busy in our superior NHS world thinking, well, we know everything that they need to know. So workforce development is massive, but it's a two-way street. We've done loads of evaluation, and that's part of what I've said to you already about the data analysis. So there's three things to think about. There's the scientific evidence for practice pertaining to the care of older people. And I like the nurses to be the leaders all the time, but I have to say it's geriatric medicine where the most evidence at this moment in time is pouring out of. So there's the scientific evidence, then there's your local intelligence, and that's when you just stop and you think about, I wonder how that keeps happening. And the things that you ponder on reflectively can be your audit question, or even a research question in the evidence of tomorrow that will bring you more data to work with. And then there's the number stuff. We had excellent business intelligence support during this programme. But even that you think, well, that can't be wrong, we don't really need to scrutinise that. We did, because sometimes we would get the Excel sheet that these business intelligence people work with all the numbers on, and I'd take it to that big forum and I'd say that, well, this looks to be the crack here or there or whatever. And one of those clinicians might say, well, I don't think that's right, mind. I don't see any people like that where I am, blah, blah, blah. Then when you try to bottom it out, so we were collecting data using postcodes of where care homes are. Most people in the land do it. The Care Home Vanguard, the whole 6, the national-led programme, they were all using postcodes to identify the care homes in their local area and then pull out the data. So it's flawed, it's fundamentally flawed, but it's the best that we've got. So we had to go with it. But in understanding our patient profile, we saw that every single bit of work we did, our patients were aged between 84 and 85. So we wasted our time looking at all those 65 to 79-year-olds because they were all older than that. So when we pulled out the data from the 80s and above using the postcode, it was much more accurate. Then it makes your recommendations for practice or service change much stronger. So that's an example of what we did in evaluation. The outcomes were related to the metrics, and then the pathway of care is the clinical engagement superstars. You know, if you think about leadership, everybody would say they believe in bottom up. In secondary care, they talk about ward to board, but we all know what ward to boards means, even if you work in primary care or community health services or whatever. We all get ward to board, don't we? It's just a useful phrase. But it's actually really hard. It's really, really hard. And when we set our clinical engagement forum up and we decided that we needed to work on these 7 work streams, it was hard for those individuals. So it was led by the CCG. Now, on the one hand, I would say, we're pretty neutral because we're not in provider services. Working with 9 organisations, 8 disciplines, including Alzheimer's, Age UK and so on. But it was really hard for them to go back into their areas and say, we need to change this or change that. And I think the message from that is it takes time. It takes time to build relationships. It takes time to build trust. And so because we've had 2 years to do that, we can be so much more sure. So what I'm going to do now, I'm just going to give you some examples of what we've done in relation to those work streams that achieved those metrics that I shared in the very beginning. I've said all of that. We've busted the myth. The only myth that I want to tell you that we've busted about workforce is we thought that we had a very transient care home workforce, but when we did a big bit of work with them, we found that the managers were transient and the nurses were transient, but the care support staff, the healthcare assistants, all of those other people that work in the homes, that was actually pretty stable. So that was really good for us to bust that myth. And when we invested in them in education and training, if they moved on, that group of staff tended to move to another care home. And if they stayed in Newcastle and Gateshead, where most of them did, they didn't even cross the Tyne. Most, in fact, I don't think I found anybody cross the Tyne other than the nurses. So you still were benefiting from this big approach. So that was a great thing for us to be able to bust. Because they used to say, well, they leave and they go and work in the Metro Centre every Christmas. Now they do that in the domiciliary care sector, but they don't do that in care homes. So it just let you, right, well, we needn't think about that for now when we've got such a lot. What did we not do? Well, I can tell you that we didn't do everything we wanted because we've come to an end. And we didn't stop some of the things that we didn't want to do. I'll give you some examples as we get cracking. And we certainly didn't finish everything. But all of the work can continue because it wasn't anything additional other than the little vanguard team that sat in the CCG. Now, last time I was here at one of Ken's events, the feedback that I got was we didn't talk enough about the transfer of care bag. So I know Ken's alluded to that this morning. So I thought that I would spend a little bit of time telling you about this because it is much more than the bag. It absolutely is. I think it raises the profile of care home residents in secondary care, for one thing. And that should say to the secondary care staff, do you know there's a lot of intelligence about this person out there, if you wouldn't mind just speaking to them? Because those care home staff know those residents much, much better than we ever will in our secondary care world. So firstly, I think it massively raises the profile of care home residents. And I think that I hope that it lets secondary care see all of that intelligence there is, firstly from the care home staff. But Sharon mentioned long-term conditions. Now, you know a long-term condition doesn't travel alone in frailty. People who are frail will have 3 or 4. If you let's take hypertension, blood pressure as an example. You can have 20, 30 years of long-term condition management in primary care from your GP and practice team. Yet in secondary care, we think this is the whole kit and caboodle, this that goes on in here. And we fail to see that if our patient's journey is this big, the secondary care bit is the smallest bit. But of course, this is where massive things happen to us. We'll have our lives saved, have our babies, and it's absolutely sometimes the only place to be. But it's not always. And all of that intelligence can really support one another. So I do hope that we raise the profile in secondary care of care homes and their teams. I think that it improves safety for the reasons that people can be in less, and Paula spoke about deconditioning and so on as well. So what we've done, we've developed this little pack which is available on that website that was at the end of the film. And if any of you wanted to just click on there and have a little look at it. So in the secondary care, the ward discharge nurses, Paula being one of them, they're going around all the wards telling them about care homes and this bag. And then in community, obviously, the care homes are being delivered all their bags. To introduce this, though, you've got to work closely with your secondary care colleagues because remember they've already got discharge pro formas and they're filling in discharge lists, checklists and providing a whole range of other information. So one side of the river, Gateshead or Newcastle, doesn't matter which one side of the river are adapting what we've developed, but the other side of the river prefer to stick to their own. So you've always got to have a little bit of flexibility. So it's a much bigger job than you think, just dishing the bags out. It means so much more. In terms of technology, we introduced laptops and the National Early Warning Score to support recognition of illness, because your window of opportunity is tiny. But this is what the world outside of specialist services don't know. You can be septic and not have a change in your baseline observations. So to teach somebody about temperature, blood pressure and pulse in frailty is useless unless you also teach how illness presents. So when the care home staff say, you know, he normally wanders all day and he's never been out his chair today, that's massive. Or she loves her breakfast and she's never touched it. That's massive. Now, those most experienced will jump in quick and think, hey, what's the crack here? Those not less experienced in elderly care will run straight for their obs. So we thought, well, let's measure 2 things. So this is a proper bit of work that we've got Northumbria University doing for us. And what we're finding is the Bartel, which measures function, you know, wanders all day, suddenly isn't. And the news score, that there is a statistically significant link between both of them. and that there's usually a change in your Bartell before a change. So this is pretty groundbreaking stuff. And I'm not saying that this is evidence, scientific evidence, but I'm saying that it's a legacy that we're going to leave, because Northumbria University now own that work and they'll continue with that. And what that will do is, I read something in the report that made us feel a little bit sad, actually. It was from one of the support workers. Because we bought the laptops and we did put the apps on, it's got a little NHS sticker on because it went through our CCG system to get all up and running. And one of the care home staff said, look at that, NHS, how good are we, eh? Well, actually, they were providing some of the most significant care in that older person's journey. So I think we got much more out of it than we thought we would. We also measured the clinical frailty score, if you're aware of that, the Rockwood tool. It's on our website if you want to have a look at it. And that didn't change. It was really just those are the two things. When it comes to the nutrition and hydration, I've said already we saw some fantastic hydration care. But what we also found, and this was exactly the same right across the care system, people had a nutrition and hydration policy, and hydration was a paragraph within it. And we've learned that you need to have a focus on both of them equally. It's not just about the eating, it's about the drinking. And with normal aging, you have a reduced appetite anyway, so it was more about making the most of those eating times and boosting calories and things. And we worked with some art therapists. Now, because I'm a nurse specialist for older people, and I like looking after people, which means that all that prevention stuff all you people do way down here, I like it when they're with me and I'm looking after them all. So art therapy was really new. But you know what's fantastic about the art therapists? They did a project called Imagining Drinks. And when they went around the care homes just thinking of different ways to get fluid in, we had getting your fluid from food. So you're trying to double up and having water-rich food and so on. So that was that. We've aligned our Macmillan nurses with all of our care homes now, as well as providing education and training. They attend the weekly ward round. Our model is that every care home has a linked practice and a lead GP. The lead GP does a ward round with a nurse specialist for older people and the care home teams. And so the Macmillan nurses will support them. And this is how we're starting to recognise much better you're flipping from palliative into end of life. Because remember, that's really hard with dementia and frailty. And then I always like to say this. These are 10 hospitals that we used to have in Newcastle and Gateshead. They're all elderly care hospitals and they've all gone. Now, while some of them had long-stay geriatric wards, as they were labelled, and we don't want those back. But what we did when we quite rightly flipped from that model of healthcare into a more social model in the independent care sector, we didn't flip all of that workforce. So these people had geriatricians and physios and OTs and nurses all working there all of the time, and lots of areas will be like that. Now, John Young, the National Lead for Frailty and Integration, who's just stepped down, he says that if you live in an area where you still have community hospitals, don't shut them. Now, earlier this week, I was reading the stranded patient data, and I noticed that where John Young worked, where the community hospitals were way down the list after us. And I just, I'm not saying that's right, but it's just useful to reflect on those things. What's coming out next? We're busy working on a regional frailty strategy and a regional competency framework. We've already got that. We're busy testing that. So we've asked lots of people across the care sector to self-assess themselves, and we've found that the care home staff under-assess, whereas the other staff tend to over-assess. And we've followed it up with observed practice, so that's really interesting. And there's also some national frailty strategy and competency framework, capability framework, that's expected out in May, June. So you'll see that coming as well. And that's it from me.
Thank you very much, Lesley. It's always lovely to hear Lesley speaking so passionately about the work that she's been